This crash course series highlights the classification and key features of common hematologic neoplasms. The topic can be particularly daunting, so this module is designed to help address frequently asked questions. My name is Brad Drumheller, and I'm a Hematopathology Fellow here at Penn. Before proceeding, please take this brief entry quiz to assess your knowledge. The quiz will take approximately 10 minutes to complete and is designed to reinforce the high-yield topics covered. Valuable in-depth feedback is provided upon submission to really help you master this material. The exit quiz follows the same format and is meant to test your understanding upon completion of this course. These questions are part of an academic educational research project, and as such, there is a brief consent explaining how your responses are anonymous. Please note that these quizzes utilize Google Forms, which may be blocked on a campus computer. This is due to a firewall affecting Google web pages. You should try accessing in a different location on a personal device or through a mobile hotspot. The video is divided into 5 short segments, starting with a broad introduction to blood cell development, reviewing the differences between leukemia and lymphoma, and diving into each category, starting with acute leukemias and related neoplasms, and ending with Hodgkin lymphoma. Let's begin by building a strong foundation. By the end of this section, you'll be able to identify hematologic cells on histology, summarize the different pathways of hematopoiesis, and differentiate between leukemia and lymphoma. The classification of hematologic neoplasms is made with a combination of morphology, which is the appearance under the microscope, clinical presentation, and genetics. Keep in mind, many disorders we discuss are now being classified based not only on these features, but also by the molecular and cytogenetic alterations that drive the disease. Before we start, it's important to discuss some different sample types used to evaluate patients with hematologic neoplasms. The first type is a simple blood smear. A slide is made by applying a drop of blood and smearing it across the slide. 3 normal circulating components are white blood cells, red blood cells, and platelets. The quantity of different cells is compared to an age-adjusted reference range to detect any increases or decreases that may deviate from a normal population. The second sample type is a bone marrow biopsy, commonly taken at the posterior iliac crest. Typically, both a core biopsy and a marrow aspirate are taken to review the cellular elements and perform additional testing, which is outside the scope of this review. Lastly, tissue biopsies of a lymph node or another site can be performed to rule out involvement by a lymphoma. These are often performed when a lymph node is found to be abnormally large. Lymph node biopsies are also important for diagnosing metastatic disease and for tumor staging. Great, now we have our samples. Let's review the normal components and their neoplastic counterparts. Human hematopoiesis, the production of mature blood cells, starts in the bone marrow with the pluripotent or multipotential stem cell, which is shown at the top of the diagram. This cell gives rise to an early progenitor cell, a stem cell restricted to the lymphoid and myeloid lineages. The lymphoid stem cell matures into B cells, T cells, and NK cells. The myeloid stem cell matures into all other blood cells, principally megakaryocytes, red cells, granulocytes, and monocytes. As marrow cells mature, they are released into circulation, where some ultimately reside in tissues. This is an important concept to grasp, since many hematologic diseases can be traced to a defect in the hematopoietic pathway. Here is another illustration highlighting the cellular morphology. Notice how the granulocytic, megakaryocytic, erythroid, and monocyte production all branch from the myeloid lineage. The mature cells spill into the blood and constitute normal counterparts on a blood smear. Mature lymphocytes are also found in circulation. Plasma cells are primarily found in tissues. Erythroid and myeloid pathways show analogous differentiation. As they mature, the cells get smaller, their chromatin condenses, and the cytoplasm changes. Granulocytes gain granules and red blood cells gain hemoglobin. The nucleus of granulocytes also becomes segmented. To learn more, you can check out Cell Atlas, a smartphone application with excellent pictures and detailed descriptions, which is referenced here. Now let's focus on hematologic neoplasms. It's important to define some terminology first. Leukemia is a neoplasm affecting the bone marrow and ultimately, because marrow cells circulate, the peripheral blood. Lymphomas involve tissues, often lymph nodes or spleen, the suffix "oma" here meaning solid tumor. In some instances, the neoplastic cells can involve both compartments, however the nomenclature usually denotes the tissue of origin. For example, follicular lymphoma, which typically arises in a lymph node, is called follicular lymphoma, even if it involves the bone marrow. An exception to this rule is chronic lymphocytic leukemia, small lymphocytic lymphoma, CLL, SLL, since this disease usually involves the bone marrow, blood, and tissues. Mirroring hematopoiesis, the classification of hematologic neoplasms can be divided broadly into lymphoid and myeloid disorders. Myeloid maturation occurs in the bone marrow and eventually involves the blood. Myeloid neoplasms, therefore, are mostly leukemias. Lymphoid neoplasms can arise early in maturation as bone marrow disorders, leukemias, or once B cells and T cells mature and leave the marrow for secondary lymphoid organs, as solid tumors, lymphomas. In other words, leukemia can be either myeloid or lymphoid. Lymphomas are generally lymphoid. By the end of this section, you will be able to distinguish between acute myeloid leukemia and acute lymphoblastic leukemia lymphoma, identify the translocation associated with acute promyelocytic leukemia, as well as the treatment, and finally summarize the differences between the myeloproliferative neoplasms. Acute leukemia is caused by a neoplastic proliferation of immature marrow cells, or blasts. These neoplastic cells have two fundamental problems. They proliferate wildly, and they suffer from a differentiation block, meaning they can't mature. The result is an accumulation of immature cells, which then spills into the peripheral blood. The replacement and crowding out of normal marrow cells often leads to decreased normal mature cells in circulation, leading to anemia, not enough red cells, leukopenia, not enough mature white cells, and thrombocytopenia, not enough platelets. Blasts can be derived either from the myeloid lineage, myeloblasts, giving rise to acute myeloid leukemia, or lymphoid lineage, lymphoblasts, giving rise to acute lymphoblastic leukemia. Acute myeloid leukemia is a neoplastic disorder of immature myeloid cells, myeloblasts. The risk increases with age and is therefore more common in adults. Additional risk factors include a history of prior chemotherapy or radiation, benzene exposure, and Down syndrome. Patients present with symptoms related to marrow infiltration, including fatigue, anemia, bleeding, thrombocytopenia, and infection, low number of functioning white blood cells. An additional symptom is gingival hyperplasia, which is caused by an infiltration of leukemic blasts into the gums. Blasts may contain hour rods, which are pink cytoplasmic needle-shaped crystals caused by an abnormal fusion of primary azurophilic granules containing myeloperoxidase, or MPO. Acute promyelocytic leukemia, APL, is a unique subset of AML with a favorable prognosis. However, most patients initially present with a life-threatening consumptive coagulopathy, termed disseminated intravascular coagulation, abbreviated DIC. The leukemic cells produce excess tissue factor, which activates the coagulation cascade and creates tiny blood clots, called microthrombi. Platelets and clotting factors are consumed this way, giving rise to an increased bleeding tendency from multiple sites, such as the GI tract. Therefore, early recognition and treatment is critical. Histologically, blasts can contain numerous hour rods. The characteristic translocation is translocation 1517, involving the PML-RARA genes, or RARA. RARA is a retinoic acid receptor alpha gene, which may help you remember the important treatment, a vitamin A derivative called all-trans-retinoic acid, which is abbreviated ATRA. Acute lymphoblastic leukemia is a neoplastic disorder more common in children, with an increased risk associated with Down syndrome. In contrast to AML, blasts often express terminal deoxynucleotide transferase, TDT, and lack hour rods. There are two flavors of ALL with a propensity to present in different sites. B-ALL, arising from B lymphoblasts, more often presents in the bone marrow, with symptoms related to bone infiltration including decreases of mature cells in the peripheral blood and bone pain. T-ALL can form a thymic mass, T for thymic, with symptoms related to compression of surrounding structures. Myeloproliferative disorders are due to the uncontrolled proliferation of one or more myeloid cell lines, granulocytes, erythroid cells, and megakaryocytes, leading to an increase of mature progeny, neutrophils, red cells, and platelets, not blasts, in the periphery. Splenomegaly is usually present. While there is overlap between these diseases clinically, chronic myeloid leukemia, CML, is characterized mainly by the overproduction of granulocytes. Polycythemia vera, PV, is characterized by an excessive production of red cells, and essential thrombocythemia, ET, by an overabundance of platelets. A related disorder, myelofibrosis, affects megakaryocytes like ET, but has a unique natural history that won't be covered here. Each of these has the ability to transform into an acute leukemia, However, the time course and likelihood are variable. Chronic myeloid leukemia is characterized by proliferation of granulocytes, resulting in an abundance of more immature forms spilling into the peripheral blood, such as promyelocytes, myelocytes, and metamyelocytes, producing a left-shifted leukocytosis, often with increased basophils. The characteristic translocation is translocation 922, creating the BCR-ABL fusion gene and forming the Philadelphia chromosome. Because the BCR-ABL fusion creates a powerful tyrosine kinase, treatment is targeted at inhibiting its activity with kinase inhibitors like imatinib. Polycythemia vera produces increased red blood cells. Symptoms may include pruritus, often triggered by hot showers, and those associated with hyperviscosity and thrombosis, in contrast to secondary polycythemia, which shows an increased erythropoietin level. Erythropoietin, or EPO, is normal or decreased in PV. Almost all cases have a JAK2 mutation. Note that JAK2 mutations can also be seen in roughly half of ET and PMF. Treatment is variable, but often includes aspirin and recurrent phlebotomy. Essential thrombocythemia manifests clinically with increased platelet production, leading to increased risk for thrombosis and hemorrhage. Secondary causes of increased platelets should be ruled out. About half of ET cases have a JAK2 mutation. Similar to ET, primary myelofibrosis is a disorder of megakaryocytes. However, unlike ET, PMF, like the name suggests, manifests with bone marrow fibrosis. This fibrosis wraps around the cells, making it difficult to aspirate, producing a so-called dry tap during a bone marrow biopsy. By the end of this section, you will be able to outline B-cell development and maturation and summarize the different types of B-cell lymphomas. Lymphomas have historically been divided into Hodgkin and non-Hodgkin lymphomas. Hodgkin lymphomas account for approximately 20% of all lymphomas. Non-Hodgkin lymphomas account for the remaining 80%. These non-Hodgkin lymphomas are further divided into B-cell and T-cell neoplasms, with B-cell neoplasms being more common at approximately 85% and T-cell the remaining 15%. We'll first discuss B-cell neoplasms in the non-Hodgkin lymphoma category. A simplified approach to learning lymphoma classifications is recognizing the cells they arise from, the so-called cell of origin. Let's start with discussing B-cell development and associated lymphomas. The B-cell is part of the adaptive humoral immune system. Early B-cell development starts in the bone marrow, B for bone, as a hematopoietic stem cell. B-lymphoblastic leukemia lymphoma, previously discussed, is the precursor B-cell neoplasm that begins at this early phase of development. Remember, B-ALL is TDT positive. Cells mature, turn off TDT, and leave the bone marrow. The naive B-cell is a mature B-cell which has not yet encountered an antigen. These cells eventually form primary lymphoid follicles and mantle zones in peripheral lymphoid tissues, such as lymph node and spleen. When naive B cells encounter an antigen in the germinal center, they further differentiate into centroblasts. This creates the dark zone of the germinal center. Centroblasts rapidly divide and differentiate into centrocytes, which occupy the light zone of the germinal center. During this development, cells undergo somatic hypermutation and class switching. B cells with decreased antigen affinity undergo apoptosis and are cleaned up by tingible body macrophages, and those with high antigen affinity are rescued from cell death, selection. Follicular lymphoma, Burkitt lymphoma, some types of diffuse large B-cell lymphoma, and Hodgkin lymphoma are thought to develop at this stage. After selection, B cells leave the germinal center to form memory B cells and plasma cells. Marginal zone lymphoma, subsets of CLL, SLL, and some types of DLBCL develop from this stage. Myeloma is also included here, since it develops from plasma cells, but remember, myeloma is not considered a lymphoma. Here is a tissue section demonstrating a normal lymph node contained by a pink fibrous capsule. Notice on high power that the germinal center is polarized by a dark zone and a light zone with the surrounding mantle. The paler pink cells seen in the germinal center are tingible body macrophages, cleaning up those cells undergoing apoptosis. Again, we can see the outer fibrous capsule. Now we'll discuss the most important types of mature B-cell lymphomas. CLL, SLL is the most common adult leukemia, often occurring in patients over 60 years of age. It is often an indolent disease with slow but gradual progression and is associated with lymphadenopathy and hepatosplenomegaly. Lymph nodes show diffuse effacement with cloud-like proliferation centers. Patients have an elevated lymphocyte count with small fragile lymphocytes that are easily disrupted, resulting in smudge cells on peripheral smears. A complication is transformation to a higher grade lymphoma, most commonly DLBCL, which is called Richter Transformation. Follicular lymphoma is the most common low-grade B-cell lymphoma in adults. Patients present with generalized lymphadenopathy. The disease often has an indolent, waxing and waning course, but may eventually undergo transformation into a diffuse large B-cell lymphoma, which carries a poor prognosis. Tissue sections demonstrate numerous back-to-back follicles, lacking tingible body macrophages, with loss of normal polarity. The characteristic translocation is translocation 1418, involving the IgH heavy chain and BCL2. Note that the heavy chain locus on chromosome 14 is involved in many other B-cell lymphomas. Diffuse large B-cell lymphoma, DLBCL, is a common aggressive lymphoma which can arise either de novo or after transformation from a more indolent lymphoma. There are many subtypes, and immunodeficiency is a major risk factor. DLBCLs arising within the germinal center, GCB type, have a better prognosis than those derived from non-germinal center or activated B cells, ABC type. DLBCL, like the name suggests, is characterized by diffuse sheets of rapidly dividing large cells on histology. Burkitt lymphoma primarily affects children and young adults. There are 3 variants of Burkitt lymphoma, with variable EBV infection rates. The endemic form is strongly linked to EBV and found in the malaria belt in Africa and Central America. The sporadic form is more common in the Western countries. The immunodeficiency associated form is found in HIV patients and seen in older adults. Histology shows diffuse sheets of medium-sized cells with numerous tingible body macrophages, which imparts a starry sky appearance. The characteristic translocation is translocation 814, involving the IgH heavy chain and c-MYC. The translocation is easy to remember since the B in Burkitt looks like an 8. By the end of this section, you will be able to summarize the CRAB symptoms and recognize the laboratory testing important in plasma cell myeloma. Multiple myeloma is a common neoplastic proliferation of plasma cells. Remember, plasma cells are responsible for making and secreting antibodies, also known as immunoglobulins, and these clonal plasma cells overproduce the same homogeneous immunoglobulin protein. The risk for myeloma is highest in the elderly, African Americans, and men. The diagnosis requires a combination of clinical, laboratory, and radiographic information. Myeloma is multifactorial and causes lytic bone lesions and predisposes to fractures. Osteoclast activation leads to hypercalcemia. The secreted immunoglobulin proteins cause renal casts and kidney failure. Marrow replacement and renal failure lead to anemia. Peripheral blood smears may show long chains of stacked red blood cells termed rouleau formation, and sometimes circulating plasma cells, pictured here. Serum protein electrophoresis, SPEP, in normal patients shows a smearing pattern of polyclonal immunoglobulins. In myeloma, the monoclonal protein creates a distinct band on SPEP, abbreviated M protein. Immunofixation is a technique to determine the type of immunoglobulin and the light chain class secreted. In this case, a band is seen at IgM and lambda, indicating secretion of a monoclonal IgM lambda immunoglobulin protein. By the end of this section, you will be able to recognize the difference between Hodgkin lymphoma and non-Hodgkin lymphoma, describe how classic Hodgkin lymphoma is different from other B-cell lymphomas, and name the cells associated with classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. Hodgkin lymphomas are distinct from non-Hodgkin lymphomas. Hodgkin lymphomas follow a contiguous lymph node distribution, while non-Hodgkin lymphomas are non-contiguous, meaning they don't follow a chain of lymph nodes. Hodgkin lymphoma does not have a leukemic phase, and therefore does not involve the peripheral blood. Hodgkin lymphoma is divided into 2 distinct types, classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. Classic Hodgkin lymphoma is a special type of B-cell lymphoma. Recall that classic Hodgkin lymphoma arises from the germinal center B-cell, but downregulates expression of some normal lymphocyte markers, such as CD45, and normal B-cell markers, such as CD20, and expresses unusual markers like CD30 and CD15. It follows a bimodal age distribution with a higher incidence in younger patients and then again in older patients. There is an association with EBV infection as well as immunosuppression. The malignant cell is called the Reed-Sternberg cell, with the characteristic binucleated owl eye appearance. These cells often attract a background of mixed inflammatory cells rich in eosinophils, lymphocytes, and histiocytes. There are 4 histologic subtypes: nodular sclerosis, mixed cellularity, lymphocyte-rich, and lymphocyte-depleted, but these histologic distinctions are not nearly as important as the extent of spread, or the stage. Staging is based on the number and location of affected nodes following the modified Ann Arbor system. While this disease has a good prognosis at low clinical stages, high-stage disease carries a far less favorable prognosis. Lymphocyte predominant Hodgkin lymphoma is distinct from classic Hodgkin lymphoma. Notice the lack of classic in the name. It is an indolent disease with good prognosis and is not associated with EBV infection. The neoplastic cell is the so-called popcorn cell, resembling popcorn. Unlike the neoplastic cells in classic Hodgkin lymphoma, it retains the B-cell markers, such as CD20, and is negative for CD15 and CD30. And just like that, another topic is mastered. It's time to save some virtual patients. Please complete the short exit quiz to test your understanding. Thank you for completing this module, and be sure to leave your feedback for future improvements. This course was developed and produced by Dr. Brad Drumheller. The Scholarly Education Project was part of the 18-month medical education track directed and instructed by Drs. Ulema Luhanga and Taryn Taylor at Emory University. Review, edits, and support were provided by Dr. Dale Frank, Division of Hematopathology at the Hospital of the University of Pennsylvania.